We are going to talk about now about sympathetic block. In the sympathetic block, there is preganglionic fiber and postganglionic fiber. This uses acetylcholine and the receptor is present NN receptor. Now postganglionic fiber will go and release noradrenaline in the synaptic cleft, which will in turn activate alpha 1 and beta 1, and alpha 2, which is present in the presynaptic cleft. This use as a block or brake. It's used as a brake. So we can use agonist of this one. We can block NM receptors. We can block alpha 1 beta 1. So NN block, this is trimethophan hexamethonium. These two drugs are used in nicotine poisoning. Beta 2 agonist, which we use as a brakes. This is clonidine and methyl dopa. They have side effect like rebound hypertension, hemolytic anemia, but these three drugs are safe. Safe in what? Safe in pregnancy, but cause dry mouth and sedation. Alpha 1 and beta 1, they are in autonomic nervous system. Talk about in autonomic nervous system, this blockers. Now RAS is renin angiotensin system. What happens in renin angiotensin system? Beta 1 receptor present in the kidney, they will give impulse to the JG cells, which in turn it will release renin. Renin will convert angiotensinogen to angiotensin 1. It will go to lungs with the angiotensin converting enzyme. It will convert to angiotensin 2. Now angiotensin 2 will go to all the angiotensin 1 receptors. In the blood vessels, it will cause vasoconstriction, and in the adrenal cortex they will release aldosterone, which will in turn increase sodium intake. In turn they will absorb more water. Water will be retained in the body, so it can cause edema. Cortex will release adrenaline and noradrenaline. Now what we can do? We can either block renin, beta blockers, or block angiotensin converting enzyme. We can block angiotensin receptors and aldosterone. We'll talk about renin blockers. Beta blockers we have already told previous videos. Renin drugs, aliskiren. There is a rin in the name, kiran. Aliskiren, remikiran, and enalkiran. These are the renin blockers. This we can give by oral route also. So blocking renin release can also block beta blockers, can also block beta. So this in turn, they actually correlate. If beta is blocked, renin release will not occur. If you do not release more renin, so it will be inhibited. Now we'll talk about treatment of hypertension. Treatment of hypertension, according to Joint National Committee 8 guideline, patients BP either more than equal to 140 systolic and 90 diastolic. When to start treatment? First, we have to ask them to change lifestyle. Or modification of lifestyle. What we can ask them to do: eat low salt diet and regular exercise. First line drugs. Use A, C, D. A for angiotensin converting enzyme inhibitors or ARBs, angiotensin receptor blocker. C, we can use calcium channel blocker. D, we can use diuretics. What should be our goal? Less than 140/90 for all patients, or less than 150/90 in patients who are more than 60 years without diabetes or chronic kidney disease. Now some drug of choice. Number 1, hypertension. According to J National Committee, you should use methyl dopamine, but some books also labetalol. Number 2, hypertension emergency. In pregnancy, Joint National Committee says we should use hydralazine. Some book says you can use labetalol. Hypertension in general, you can use thiazide. And books also says thiazide. This is the first line drug. In this, both of them agree. Book and Joint National Committee. Hypertension in general, use nitroprost. which is NO, nitric oxides, and books says nicardip. What are these? Are calcium channel blockers, dipines, dihydropyridines. Safe in pregnancy. Drugs which are safe in pregnancy. Care during high pregnancy. Beta blockers, levital, hydralazine. But remember, side effect SLE also can be by ship drug. Which is alpha blocker. We'll talk about ANS. So beta blocker, labetalol, methyl dopa, clonidine, dipines, calcium channel blocker, dipine, hydralazine, prazosin. That's it. We'll meet in the next topic.